Good afternoon, or good morning, everyone. My name is Fran Phillips. I am a former senior deputy with the Maryland Department of Health and Mental Hygiene. I'm currently consulting with the Health Systems Transformation Team here at ASTHO, the Association of State and Territorial Health Officials. I'd like to welcome you to today's Delivery and Payment Reform Technical Assistance call entitled Value-Based Payments. What are they and what do they mean for public health? ASTHO, with funding from the CDC, launched this technical assistance call series back in January of 2015. The purpose of the calls is to focus on some of the key areas that states have identified for additional assistance as they move forward with payment and delivery reform. The four-part technical assistance call series consists of calls with a substantial amount of time set aside for open discussion between participants and the audience in order that you, the audience, may address questions and comments. Participants also have the opportunity and have taken this opportunity to submit some questions prior to each of these calls. Today's call is the third in the series and we'll be highlighting, as I said, on the evolving practices known as value-based payments and what implications these practices may have for public health. So turning to the next slide, the purpose of today's calls, the objectives are really threefold. First, to inform state public health as well as other stakeholders about value-based payments and value-based insurance design, which I will term VBID. Also, to discuss how value-based payments and VBID are being used to promote prevention practices and healthy behaviors. And finally, to discuss from the perspective of state public health how these new practices may impact population health. So first, let's turn to the next slide, a bit of introduction on the topic and some of the terms used. So for that, I'll offer some concepts so that we have a shared kind of basic understanding about this term, quote, value-based. Our presenters today will share their insights and experience in putting concepts associated with the term value-based into practice. As you can see on the slide, a definition of value-based approach is one which aims to increase healthcare quality and outcomes while containing costs. The term value incorporates a three-part goal of maximum quality and optimum care experience, along with financial incentives to minimize costs. So value-based strategies really do focus on achieving the triple aim. Typically, these strategies use data to measure performance and financial incentives, as I said, to promote more effective services and consumer choices. Value-based strategies tend to get different names depending on the user's perspective. So, for example, the term value-based purchasing typically applies to employers and public sector purchasers of health plans, while value-based insurance design, or VBID, refers to particular features of a plan's design intended to drive specific behaviors. So the next slide shows that providers are getting in the game as well in terms of organizing and delivering care with value in mind. Innovations such as patient-centered medical homes and accountable care organizations represent new models for providers to deliver and get paid for care differently. In these arrangements, typically there are explicit process and outcome measures for improving the overall health and satisfaction of the patient population, along with some sort of financial dividend or shared savings going back to the provider group. Reimbursement for health services, as we know, is moving from traditional fee-for-service to more value-based models. So as a result, provider organizations such as hospitals and health systems are redesigning their affiliations, their service lines, and their business strategies. Given how important healthcare spending is in our overall national economy, a shift to value-based payment is garnering interest both inside and outside the health sector, including on Wall Street, as a matter of fact. Investors there are very receptive to startups aimed at new approaches to capturing value on behalf of health systems. For example, as reported earlier this month in the Washington Post, a Virginia-based firm raised $195 million in its debut offering on the New York Stock Exchange. This is a company that deploys doctors and clinical experts to find improvements in the way hospitals provide care, as well as providing advanced data analysts to better assess health risks for patients. Moving to the next slide, this is now shifting to another perspective. This is the perspective of value-based purchasing from the viewpoint of employers or governmental purchasers who are also chasing that triple aim. Employers and public sector programs have an obvious stake in maximizing quality and containing costs. So innovative partnerships between purchasers, providers, and health plans are emerging. Federal purchasers, that largely being Medicare and Medicaid, account for over 35% of the nation's healthcare spend. So it's very significant that CMS has announced its intention to pay for, quote, value, not volume, and expects that 90% of its provider payments will be value-based by the year 2018. Likewise, employers, when purchasing employee coverage either through commercial carriers or through their own self-funded plans, are looking for benefit designs and cost-sharing features likely to slow costs without diminishing access to care. So what you see on this slide are a few types of those employer strategies. For example, some large employers are looking to preferred health systems to directly contract either through global payments or bundled care for certain high-cost procedures such as transplants or major surgeries. Another employer strategy, which actually is not on this slide, is the use of premium differentials for, on the one hand, for employers' incentives for employees to adopt healthier behavior, while on the other hand, some employers are imposing hefty premium surcharges on unhealthy behaviors such as tobacco use. As noted on the slide, many employers have developed and are already evaluating countless types of health promotion programs for employees to be used as adjuncts with their health coverage. And the last bullet on this slide references some of the value-based provisions in the Affordable Care Act. As you probably know, the federal government set design requirements for the vast majority of health plans, the so-called non-grandfathered plans offered in the country. So these non-grandfathered plans must provide benefits with no cost sharing for a number of preventive services, such as those that have either an A or a B rating from the U.S. Preventive Services Task Force, such as immunizations recommended by the ACIP, or certain evidence-based screening and other services as recommended by HRSA. So moving to the last background slide before we turn over to our presenters, this then are some examples of VBID strategies used by health plans. So we've talked about employers and we've talked about purchasers. These are the health plans themselves, who have a number of ways to drive smarter consumer preferences using plan designs to reward consumer utilization of preventive services and healthier lifestyle choices. Another VBID measure is aimed at consumers to reward participation in health risk appraisals and sometimes the adherence to the resulting health improvement plans that arise out of those health risk appraisals. Managing chronic conditions is a key aim for many VBID efforts because high-cost users with multiple chronic conditions account for a disproportionate share of spending in every large group. We'll hear in a moment how Maryland's nonprofit health co-op, for example, is developing a VBID strategy for certain of its enrollees. Pricing is an obvious VBID measure to drive plan members to high-performing providers. So two examples of the use of pricing would be lower premium prices for preferred narrow networks of providers, and then in contrast to that, higher copays, for example, for the non-urgent use of emergency rooms. So that's a very, very sketchy overview of this concept of value-based payments, VBID. Certainly our presenters will bring much more light to this whole area than I have just done justice to it. But looking forward to that. There is, if you're interested, there is a slide at the close of today's webinar with some additional resources, general resources, if you're interested in digging a little bit more into value-based payments and VBID. So a couple of items before we turn it over to our presenters. Typically, the very first question, which actually has already bin posed on today's webinar, is a question as to accessing slides after the webinar itself. And as you probably have seen, and we'll show it again, yes, all of the slides for the record will be promptly posted on the ASTHO website. And the URL address for that website will be posted on a slide at the conclusion of the webinar. And lastly, at the conclusion of today's discussion, you'll be asked to jump over to do a really quick evaluation of the webinar, which we hope you do. We hope you take, it's just a minute or so, and we hope you take the time to do so. So going to our next slide to introduce our three really outstanding presenters that we have joining us today. We are really fortunate to have this degree of expertise for our discussion, all of whom have really impressive CVs. Trust me, in the interest of time, I will need to abbreviate their very rich backgrounds, but hopefully I'll do so in a way that captures a little bit of their really broad expertise. First, we'll be hearing from Dr. Peter Bielenson, who currently serves as the CEO and President of the Evergreen Health Co-op, which is Maryland's first and sole health co-op authorized by the ACA. Prior to founding Evergreen, Peter's entire career was in public health, where he led many very bold and sustained policy advances while serving as City Health Commissioner for the City of Baltimore and as County Health Officer in Howard County, Maryland. And I can speak personally on this. Peter has been a friend and colleague of mine for over 20 years, and I can tell you that his leadership in Maryland and beyond has been a consistent voice for action and for innovation in all of healthcare. Following Peter, we'll jump over to New York State, where both Greg Allen and Hope Plavin will be presenting on some of the just tremendously innovative programs there in New York State. First with Greg, who is the Director of Program Development and Management in the Office of Health Insurance Programs with the New York State Department of Health. Greg is responsible for Medicaid services planning and policy, in addition to the development of innovation in multiple program areas. Greg also is the lead responsible for managing the state's recently approved $8 billion Medicaid waiver. And then we'll hear from Hope. Hope Plavin is currently Acting Director of the Innovation Center at the New York State Department of Health, where she is charged with managing New York State's Innovation Model Testing Grant. She has over 33 years of experience in New York State government, holds multiple degrees, and is currently completing a master's degree in healthcare delivery science at Dartmouth College. So with that, we will turn to our three presenters in that sequence, after which we will open up the call to your questions and to your comments. Look forward to that. So turning it over to Peter.
Thank you very much, Fran. And Fran is our board chair and a wonderful colleague, as she was saying, for the last 20, 25 years. You can see our quick slide. I'm going to talk briefly about our high performance network, which is a value-based insurance design, and then specifically talk about our VBID, our value-based insurance design on diabetes, because that illustrates the whole issue of value-based insurance design best, I believe. So very briefly, we're Evergreen Health. As Fran mentioned, we're a co-op. There were 23 nonprofit health insurance co-ops governed by their members, set up as sort of the new market entry into the commercial insurance market by the Affordable Care Act, with many of our hands tied behind our backs, making it difficult to compete against the big insurers. But many of us have been fairly successful, and we're now over 20,000 members in both the individual and small group market on and off the exchange. So I am, although a big single payer advocate, I'm ironically now a CEO of an insurance company. But we're trying to do things the right way, and innovation is one of our major highlights in our plan. And so we're looking at trying to create an innovative approach to reimbursement and benefit design, because A, as the first line of this slide shows, we cannot sustain the kind of expenditures that we're doing as a country for much longer. We're spending, as everybody here on the call knows, 18+% of our GDP on healthcare, and that simply is not sustainable. And most current standard payment methodologies, the ACA's efforts notwithstanding, still incentivize volume, not value, and therefore tend to be almost purely fee-for-service. So we're trying to change that here at Evergreen, as are several others. So the idea behind the value-based insurance design, of course, is to reward for value, and in doing so, as Fran was mentioning, you get to the triple aim, including patients receiving better care and better outcomes. So our first innovation is a high-performance network, which is the next slide. Let me see if I can connect this here. And our high-performance network, as you can see in the bullets, is basically an exclusive, not really terribly narrow network. I know we're talking to people from all over the country, but basically our high-performance network is confined to the I-95, the Interstate 95 corridor here in Maryland between sort of Baltimore and Washington. And we've chosen 3 major hospital systems, their providers, their specialists, the labs, et cetera, along with the primary care offices that we run as our health cooperative as well. And that is our sort of narrow network. You need to use those providers in order to be covered by this network. And in return, we've been able to reduce prices significantly because we've been able to negotiate better deals with these providers, and we're doing gain sharing. As Fran had talked about at the beginning, there's gain sharing that goes on in some of these value-based insurance design where we share based on outcomes that are the result of the better care provided by our high-performing network. So I'm skipping ahead a little bit here on the slides, but basically there are 4 components of our high-performance network with shared savings. Number 1, again, market competitive payments. We've been able to negotiate lower prices with our providers and our hospital systems because they get rewarded with gain sharing if outcomes are improved. Again, I've talked about the quality and efficiency. And we provide, in order to ensure that our providers are providing patient-centered medical home model, we provide an additional incentive payment, if you will, for care coordination, for things like keeping your hours, open hours later, for doing electronic connections with your patients, for having different hours on Saturdays and Sundays, et cetera. As well as adhering to the evidence-based guidelines that we use. And if you keep your costs down and meet your quality outcome measures, you get a payment gate basically swings open. So the quality measures are not how many patients you see, which is the way that things have been rewarded in the past. It's actually outcomes that we negotiate with our hospital providers, hospital and hospital system providers, negotiate with them directly on what outcomes they want to focus on. So for example, one of the 3 hospitals is focusing heavily on diabetes control, another on hypertensive and congestive heart failure. And so if they meet those outcome goals, and they're set fairly stringently so that they're not easy for them to get, they get gain sharing. So in other words, there's basically a global budget for the 3 hospitals and their healthcare provider systems. And if we keep costs down and outcomes are met, then the gain sharing is spread about between the health insurance company, ourselves, Evergreen Co-op, and the providers who can share it predominantly with their primary care folks. So that's sort of a high level. But as part of this high performance network, we have a specific diabetes plan. And to do that, I'll switch back here to one of Fran's slides, number 6. Excuse me a second. To highlight that. So we've identified as our biggest high-cost users, the biggest chronic condition that drives our healthcare costs in our health insurance plan is diabetes, not uncommon in the rest of the country. 5% of our patients cost 50% of our spend, which is actually holds true across the country as well. And diabetes is one of the major reasons for that, particularly type 2 diabetes, of course. So again, the point of this, of using the value-based insurance design, is to push people to use smarter choices and behaviors, both patients and providers, for better management of chronic conditions. And again, we use preferred providers. And we're trying to encourage patients and providers to use evidence-based care by reducing or eliminating financial barriers to that care. So for our diabetic patients in our high-performance network, we charge no copays and waive the deductibles and charge no coinsurance for glucose strips, for hemoglobin A1C lab tests. That's the lab test, as most of you know, for how you're controlling your diabetes over a period of time. No copays, coinsurance, or deductible used for podiatry visits, for eye doctor visits, for endocrine doctor visits, for primary care visits. Obviously, trying to remove all barriers to economic barriers to the appropriate evidence-based care that will keep diabetics healthy and keep them from having the severe consequences that many get with diabetes, from blindness to diabetic foot disease to amputations, et cetera, et cetera. That's the goal, and we think that that can be replicated with other major chronic conditions, and we will be looking to do that in our insurance plan going forward. I will also say that in addition to our high performance network, throughout all of our health plans, our health products, including our HMO and our point of service plans, we also have a mini VBID, mini value-based insurance design, in that for all the top 7 chronic conditions, asthma, depression, high blood pressure, congestive heart failure, and diabetes, among others, all generic meds across all of our products, of health insurance products, are free of copay and deductible and coinsurance. And that's to encourage people, again, by removing economic barriers to care, encouraging them to do the appropriate thing that is evidence-based, that will hopefully keep them healthier, and, by the way, help the bottom line of the insurance company. So it's sort of the sweet spot of the Affordable Care Act by doing so. Let me stop there, and I'll turn it over to my New York colleagues, and we'll be happy to take questions when we're done.
Thank you, Peter. This is Fran, and I just want to remind the listeners there's a tremendous amount of information to absorb, and I bet quite a few questions. So feel free to enter those questions in the chat room to make note of those questions. There'll be an opportunity afterwards to pose them either via audio or through the chat room. So thanks for that. And Greg, you're on. Go ahead. Thanks.
Thank you very much. Thanks for that great presentation, Peter. So on the next slide, I'll just do a quick review of the presentation. I'm going to very quickly do a little level set on where New York's gone on Medicaid reform. Hope we'll bring this up a level later and talk about really sort of how we're viewing the state from the SHIP and SIM and the all-payer perspective, and a little deeper dive on our work on advanced primary care. But I'm going to focus on Medicaid here in the state, and I'll give you a little background of where we've come from and how payment reform really fits into our landscape here. I need to just talk a little bit about our Delivery System Reform Incentive Payment Program, or DSRIP, which comes out of our Medicaid waiver, because that is driving the Medicaid payment reform and is the backdrop for that. And then I will more specifically get into payment reform without trying to make anybody an expert in payment reform. Hopefully this will just interest some states in the approach that we're taking here in New York. So next slide, please. So just a little background. We are now enrolling 6 million individuals in New York in the state Medicaid program. We've been expanding that program quite rapidly. Especially since 2012. We rank second in the nation after California. We're almost insuring a third of the state's population at this point. And we rank second in spend. We're probably going to eclipse the $60 billion mark here relatively shortly. So we're a fairly large insurer. Next slide. As we started looking at Medicaid redesign when Governor Cuomo took office, we were looking at our data, and we clearly had a healthcare crisis. Our greater than 10% growth rate had just simply become unsustainable. We didn't have the tax base. Our property taxes were beginning to suffer greatly. We were becoming completely non-competitive on the national scenario, and a lot of that driven by the usual budget issues, but Medicaid was becoming completely unsustainable. And on our cost per recipient were double the national average, and despite all that spending, we were embarrassingly 50th in avoidable hospital use, and while getting better, we still have a lot of work to go in that category, and we were 21st on overall healthcare system quality. And again, I think we had excellence within silos, but where we really struggled was in coordination between silos of care. Our previous attempts to fix this really had mostly been around across the board, politically doable rate kinds of cuts, which really did not leave us with a very sustainable picture. in terms of low rates, more people being insured, and all of these problems that we're having on the quality side. Next slide. So when Governor Cuomo took office, he built with our Medicaid Director, Jason Helgerson, something we called the Medicaid Redesign Team. We put a group of 27 stakeholders in several rooms over an intense period of time, and their job was to develop this set of recommendations to lower spending while trying to reform the program. We were closely tying to the implementation of the ACA, and we implemented several ACA programs in the midst of this transformation. And we developed a multi-year action plan, and the waiver was one component of that, and we're still implementing that action plan today. Next slide. The key components of that, even though we had many, many programs that were implemented over several waves, the most important are listed here. The first was a global spending cap, where we actually implemented a statutory cap on our growth in Medicaid spending, and if we could not get to those to live within that cap, then the Commissioner of Health received superpowers from the legislature to reduce spending in line with the cap. And we publish monthly summaries of how we're doing, and thus far, 3 closed years in and about another half year in, we've been able to keep spending under that global spending cap while increasing access to care and lowering costs. We implemented Care Management for All, which included moving more services and members to Medicaid managed care and building out many care management programs like the patient-centered medical homes and health homes were key components of our strategy to manage that high-cost, high-need population that Peter was talking about. And at the same time, as we were saving dollars, we were beginning to reinvest those savings into social determinants programs. And we took state money that we were saving through our Medicaid Redesign Team and, for instance, began to purchase market rate housing, supportive housing, and transitional housing for our members, and implemented many other innovative strategies around health disparities. Next slide. So we have successfully reduced our Medicaid spending despite the fact that we grew over 12% the number enrolled in the program since 2011, and we have now reduced our per recipient spending to below our 2003 levels. Some of this was a result of case mix, but we track each of these reforms and the savings associated with the reforms, and we can break down the spending by that was related to case mix and that was related to assertive program implementation. And so we have been successful at reducing cost across sectors, and we have analytics to show where those savings are coming from. Next slide. So despite the fact that we were successful in implementing some reforms to the program, we still have the program that we came into reform, and we still have some of the structural issues that we need to resolve. So we went to the CMS and we showed them we had saved them $17.1 billion in federal savings over a multi-year period related to those Medicaid redesigns. And we asked them to reinvest with us $8 billion over a 5-year period, $6.4 billion of which will be going out to our Delivery System Reform Incentive Payment Program. And the bullets of what the waiver is getting at, reducing cost and improving quality, are in the next bullet. Next slide. Thank you. So our DSRIP program, Delivery System Reform Incentive Payment Program, was really designed to drive accountability and value and make our program more patient-centered, transparent, and collaborative. And we do that by building out these enterprises we call performing provider systems, or PPSs. Could I have the next slide, please? So this PPS is a network of hospitals, primary care practices, their nursing homes, our clinics, behavioral health, home care, healthcare support agencies, all kinds of community-based organizations come together. We've approved 25 of these across the state now, and their job is to do a comprehensive community needs assessment, which they did last summer, put together an application and a project plan to implement one of several projects against a preprint list of evidence-based or evidence-informed projects that they build out over 5 years. And the statewide goal here of all these PPSs is to reduce avoidable hospitalization by 25%. That includes both emergency room and medical, surgical, and behavioral health admissions. We also have a subcomponent of the project to help very vulnerable safety net hospitals survive financially during this period. But the major focus of these efforts is quality improvement. And in order to do that quality improvement, everybody understood we had to do payment reform as a part of this. Next slide, please. So it was our firm belief and the belief of the MRT stakeholders and the belief of CMS as part of the waiver negotiation that we could not transform our delivery system into one that was cost efficient and quality focused unless we changed both the financial and the regulatory structure underneath that. Right now, even though we enroll members in managed care, the majority of those managed care payments, even though we have many innovative programs that have been implemented, the majority of those payments are still going out in fee-for-service. And so people are still being rewarded for more volume. So we always say that a hospital makes more money right now on a readmission than it does on an ED diversion with putting home care in place. When you prepay or pay based on quality and you can change the incentives, I think we got a much better shot at producing a more quality-focused and less volume-focused healthcare delivery system. Next slide, please. So just a quick review of our payment reform. Next slide. So by 2019, which is the 5th year of DSRIP, we are requiring under our waiver that our managed care organizations will be paying at least 80 to 90%. We're still working this out in our roadmap of their provider payments under a value-based payment arrangement, and we'll look at what that looks like in a minute. And we've put together a 5-year value-based payment roadmap with another stakeholder committee that is assisting us with building out these reforms. The state and CMS are fully committed to this roadmap, and we're doing alignment activity with Medicare and on the commercial side. And we've had the secretary in to speak to our providers in the Bronx, echoing the state and CMS's commitment to this. And we brought all our core stakeholders into this group that's been building this roadmap, the hospitals, other provider associations, our managed care organizations, labor's represented, as well as patient advocates at this table that's producing the roadmap. And again, if the roadmap goals are not met, part of the DSRIP program would reduce our DSRIP dollars proportionally to all of our PPSs. So we have to hit our PPS goals and we have to hit our value-based purchasing goals as well. Next slide. So what we're trying to basically do here, and this is particularly true of large healthcare systems like hospitals, right now, if they make very rapid moves towards picking value over volume, they often do that at peril to their bottom line. So if I work assertively at reducing my med-surg admissions, I'm going to make less revenue. If we change the payment equation so that entities are paid for value and paid for quality, maybe even prepaid, we can create a future state where when you do the right thing, your margin goes up, instead of when you do the right thing, your margin may go down. And we're just trying to reverse that basic premise right now, that as I avoid an admission, I get less revenue. Next slide, please. So this shows the way that we start to break this out. Our value-based roadmap is really a set of options for plans and providers to choose from when thinking about how to pay for health care. So on the left-hand side, we've got our sort of advanced practice, patient-centered medical homes. We may bundle those payments, look at population health on a risk-adjusted total cost of care basis, and plans could contract with PCP practices or independent practice associations on a total cost of care. But we are also, and this is particularly for our multiple chronic population, for people with episodic issues in the healthcare delivery system like maternity care and depression, we will create some packages or some bundles that will be options for pricing chronic condition management. And those could be subpopulation focused, they could have specialized outcome programs, and they could have those costs that were relevant to each of those populations contained in some individual pricing packages which we make available as options for contracting between the plans and the providers. The next slide. This all basically this menu of options allows the plan and the providers to basically pick some progressive quality-focused options and get to progressive risk arrangements as the provider capability comes up over the developmental life cycle here. But this is to say it's not a cookie-cutter approach, and there are several options for the plans and the PPSs or subgroups of providers within those performing provider systems to contract with. Next slide. So we have laid out value-based purchasing along three levels. Level one is basically a fee-for-service payment, but with an upside available if you hit certain cost and quality outcome measures. This can be complemented by PMPMs that may reward, say, certain levels of patient-centeredness, et cetera. Level two is sort of fee-for-service with some risk sharing on the upside and the downside, maybe on some corridors here, looking to pay the core payment in fee-for-service, but if you don't hit certain cost or quality measures, then you may get less money. If you hit certain cost and quality measures on the positive side, you end up getting more money. And then level three is when we think about paying someone on a prepaid basis. It's prospective capitation. There could be a quality or an outcome withhold as part of that, but the core payment may be paid on a PMPM basis and capitated to the enterprise. We count anything in this continuum as part of that 80 to 90% of dollars, but we are trying to get greater than 50% of the cost captured at level two or higher, and Medicare has a similar approach where they're trying to create percentages for various levels of integration on the value continuum. Next slide. So this just basically shows it's very important for us to get data in the hands of the plans and the providers to feed this discussion, and so we are building episode groupers and episode cost and quality measures that tie to the various options that we're giving. Next slide, please. So this is an example of some of the data we provide. This is particularly on perinatal care, comparing various providers. And the bars are the average cost, and the dots are the complication rates. So, of course, we'd be trying to drive providers to lower costs and lower complication rates. And we see some of the providers on the bottom of the graph that look potentially closer to what we're looking like and what we want the system to look like. And then we see some great variability in cost and in complication rates. What we're really looking to do is use payment as an incentive for shorter bars and lower complication rates, and use the public provision of this data as a way to help providers to learn from one another and also create a little peer pressure on improving quality and lowering cost. Next slide. We do believe that value-based insurance design, as was discussed, is key here, and that we have to bring providers into stimulating the right kinds of healthy lifestyle choices, and that will be part of our March to Payment design, and we'll talk a lot about that because others will. Next slide. And then we are working on a performance portal that would allow providers, health plans, and eventually even members to have access to the quality data. We're building accountability, improvement, and value-based views. We do attribute patients to these PPSs, and so they will be able to get looks at their attributed population and subgroups of that in this tool. And it shows gap to goals against the measures, and DSRIP pays based on performance of outcome measures. And we'll give people monthly updates on how they're doing in those goals. And we got geo heat maps for hot spotting and other pretty cool analytics, which I'll give you a picture of here in a second. Next slide. So this shows our beginning wireframes of the dashboard that show red for not on track, yellow for okay, not great, and green for when measures are on track. This is broken by the domains in DSRIP, broken down further by the projects, and a lot of this data is drillable right down to the patient level. Next slide, please. This shows the next cut where you can actually look at your measures for a particular project. This project is 3AI, or Integration of Primary Care and Behavioral Health. This shows all the measures that are relevant to that project and the gaps to goal. You have to have a 10% improvement against the statewide target in each year. And this shows on a monthly basis how they're making progress on each of those measures with drill-ins. Next slide, please. Those drill-ins then, now we're looking at one measure, which is potentially preventable visits here for people with behavioral health diagnoses. and we can see trends on that. We can see the geography for those PPVs, and then we can break in the right. We can break this down by primary care practice or by practitioner. Next slide. And this ends up showing the actual members down at the practitioner. So we drilled from the top of the trees for all the PPSs to one PPS, to one project, to one measure, to one practitioner, and now that practitioner gets to look at the health home these members are enrolled in and a variety of other claims and encounter data. Eventually this will be married to medical record data as well. Next slide. So I think we're going to go probably to Hope at this point and then do questions at the end, but it might be a good time to be thinking about all the things that I didn't answer.
Thank you, Greg. Now we'll move to Hope for her perspective on value-based purchasing and payment in New York State's SIM testing grant.
All right. Good afternoon. Yes, I'm right here. Good afternoon, everybody, and thank you. And you might want to take a break, Greg. That was an immense amount of information. So hopefully you are thinking of questions. I'm going to go over our State Health Innovation Plan, lead into our State Innovation Model Testing Grant, and talk about the value proposition that was embedded in both of those. So this slide looks at what we call our pillars and enablers. It's really our attempt to graphically portray the entire healthcare system in the parts that we thought the chunks we could address. You know, it's important to note that obviously not one of these pillars nor the enablers can be done without the other. It needs to be done as a whole, and I'll get to a little bit of that in a second. And Greg also just alluded to, you can't do system change without payment change. It needs to go hand in hand. Of particular note today is Pillar 4, pay for healthcare value, not volume. We really approached this from two different perspectives, which I'll get into. One was payers and providers developing a new model of care, an advanced primary care model, and how do you pay for that in a way that incents your objectives from both the payer perspective and the provider perspective and the consumer perspective. How is it better care? How is it reasonable from a payer perspective in that it increases your margin, it's a good investment? And how is it good from a provider in that it allows you to practice medicine in the way that you feel best doing so? The other piece of that is from the patient perspective is VBID, which I'll get into at the end, which again is how do you design an insurance package with a set of financial incentives that promote what is believed based upon literature and clinical recommendations to be the best care and disincent those services that are less desirable. Next slide, please. The overall SHIP objectives and goals are stated on this slide. I would really call your attention to the goals at the bottom. Number one is achieving top quartile performance in adoption of best practices in disease prevention and health improvement. That's a key part of our advanced primary care model that I'll get to, which is promoting population health, achieving high standards for quality and consumer experience. And then number three, promoting the most efficient use of healthcare resources by shifting care to the most appropriate settings, reducing avoidable hospital admissions and readmissions, and ensuring that clear link between cost and quality, which the two previous speakers spoke to quite well. Next slide, please. So this is the heart of the SHIP. This is the advanced primary care model that I spoke of. It's still in development. That's why it says draft across the slide. And it's three-tiered in an effort to really address different places that primary care providers are at right now. Smaller independent practices may be at one level of capability and interest in terms of evolving to a value-based payment strategy. Larger practices, hospital-owned practices, may be at a different place completely, but we want everybody to move in the same direction, everybody to move along the spectrum from left to right on the bottom bar as we progress through the different layers of quality and payment models. A key part of this is the integration of population health and paying for team-based care. So when we talk about value-based payment in the context of the SHIP and the advanced primary care model, that's really what we're thinking about. How do you pay to provide this care that under the fee-for-service structure is not paid for? How do you pay for care coordinators and care managers? How do you pay for having your office open when patients need to be there? How do you pay for that linkage between the clinical provider and the population health provider? So these are all pieces we're still struggling with, but when we're talking about value and payment, that's part of our goal. Next slide, please. These principles I present, they're from Health Affairs. So we copied them because we thought they were so good. But the 4 points really are key, is that healthcare cost containment and affordability can't be achieved without delivery system transformation across multiple aligned payers. When we were vetting the SHIP and talking to people and soliciting feedback, one of the consistent themes that we heard is that there are too many rules, too many measures, they're too different, they're not aligned. And if there were a way to bring some harmony, that would be better, that would be more efficient, and that would help make sure that everybody was truly incented to move in the same and consistent direction. Second bullet, delivery system transformation is predicated upon access to high quality primary care and supporting services, and that really supports why our focus is on this advanced primary care model. That's the heart. If we can start there and keep people healthy, that meets best our end goal. High quality primary care is more likely to occur in a formally recognized patient-centered medical home setting. The APC model that we developed is absolutely based upon patient-centered medical home and other similar models throughout the state and throughout the nation that have really proved promising in improving care and reducing costs. And then the last one, primary care transformation can only be successful in the multi-payer model coupled with collaborative learning and team-based care. Next slide, please. So I included this slide to really talk about population health, the potential practice expectations related to population health, and how do we pay for this? So that's the question at hand, is for all of these bullets, and these are things that are included in our advanced primary care model, we want to make sure that there's a way to pay the practice for this, and that will bring value to the system. Next slide, please. I think Greg actually just said this very well, that delivery system reform and payment reform are both necessary and they're complementary. You can't do one without the other. You need to do them together. All right, next slide. Actually, next two slides after this one. I think our moderator also went over this. This is just the spectrum of value-based care. What is it? What counts? Greg presented what's been developed as the rubric for the Medicaid model in New York State. Medicare has their own rubric, but I think they really all align and include some combination of all of these elements. Next slide, please. In talking about high value payment for advanced primary care, we go back to these building blocks from Harold Miller. Maybe you've all seen this before, but the 4 pieces: flexibility, accountability for spending, accountability for quality, and adequacy of payment are all key and have to be in the forefront when we're deciding what the payment model looks like. So we're working across payers. I should have said this in the beginning on the SHIP. It's all payer, everybody's in, and the goal at the end of the day is to assure alignment in terms of how we pay, what we pay for. How much we pay is another story, and that remains in the competitive world that we won't touch, but making sure that the incentives aligned is really critically important. Next slide, please. And at least in New York, we know that there's a lot of work already happening in this world. Our Department of Financial Services, DFS, did a survey last summer, and they just asked plans, health plans, commercial health plans in the state, what are you doing in terms of value-based payment? And what we learned is that a lot are doing a lot, Not everybody's doing everything. It's varied. It's inconsistent, but it's started. So it's not like we're starting at ground zero. And to the extent that we can work off of, expand, and leverage what's already happening, that's all to the good. Next slide, please. So now moving to our state innovation model. So based off of the SHIP, that large chart, which is overarching, we applied for and were awarded $100 million for 48 months to implement key components of that, and we're really focusing on the advanced primary care practice model, which is a delivery system change along with a payment change to ensure consistency of incentives. So our plan is to develop a flexible framework. So this is a balance, how much consistency versus how much individuality is appropriate in the marketplace, that you will still achieve your end goals. Similarly, the value-based payment, at the moment we're talking with providers, payers, consumers, and trying to figure out what's the best model. And is it a range? And is a range okay? And is it for a pre-APC model, fee-for-service with a quality incentive okay, versus more advanced has to be a total cost of care? So those are the discussions that are happening right now. We hope to come to some consensus sometime this year so that we can begin implementation next year. Next slide, please. This is just a graph that tells us what is currently being used in patient-centered medical homes, which is the basis for our APC model. So it's fee-for-service plus care coordination. In some rubrics that counts as value, in some it does not. But that's where we are today. So obviously we want to expand that percentage. Next slide. All right, VBID. I don't want to repeat much of what's been said, but as part of the grant, New York State requested funding to engage the VBID Center, which is at the University of Michigan, Dr. Mark Fendrick, to better understand the potential of this model and discuss the possible application to New York State employee health coverage. So for those state and county individuals who are covered as part of the state health insurance plan, we're still engaging in those discussions. So we'll see how that goes, but we wanted to at least explore it as a mechanism of bringing value to our own health insurance. This is just a repetition of what is VBID, so we know it's decreasing cost sharing for high-value services and increasing for low-value services. Next slide, please. So what can the state government do in terms of VBID as opposed to an insurer? So we can encourage insurers. We can highlight and promote plans that incorporate VBID elements. We can promote those plans. We can recognize VBID in plan quality ratings. For the self-insured who are not regulated, obviously, we could develop criteria or star ratings or some other mechanism to indicate those plans that include VBID as higher value plans. Next slide, please. So our next steps is where we've asked some of our colleagues in other states to present in New York and share with us their learnings from VBID, particularly for their state employees. So we're going to learn from other states. We're going to explore, we're going to reach out to the self-insured commercial payers throughout the state and find out what's happening, because we have that survey, but we want to get on the ground and really talk to people and learn about what is going on in New York State in terms of value-based insurance design. And then finally, develop tools and templates and technical assistance for those who are interested, so we can promote this as a tool for achieving value. And I think that's my last slide, right? So now you've heard quite a bit, and I guess time for questions and answers for all of us. So thank you.
Well, thank you, Hope, and Greg and Peter. That was a tremendous amount of information in a very compressed period of time. Really highly sophisticated and in some places highly technical, but also I think as you'll hear from some upcoming questions that have either been posted in the chat room or have been submitted previously or that we'll hear online, with a great deal of relevance, these presentations, a great deal of relevance to the broader world of public health and the stakeholders that are on the call. So thank you for those tremendous presentations. And at this time, we will do a couple things. First of all, we're going to open up the line for questions, and I believe that we have an operator who can give us some guidance on submitting questions through the orally. Is the operator there that can give us that guidance? Well, I'm not hearing the operator.
If you would like to ask an audio question, please press star 1.
Star 1. Thank you very much, operator. And you'll cue me as to any questions that come in that queue. So let's turn then to the chat room, where we did get questions posted during the presentations. Some of these were directed to individuals, and some more generally. So we'll take them kind of in the order that they come. And operator, if you can interrupt me when you do have a question waiting on the line there, that would be terrific. So first off, this is a general question to any of the 3 presenters, Peter, Greg, or Hope. Comes from Cassandra Codes Johnson, who asks, what are the most promising value-based care models that seek to integrate addressing a patient's health and social service needs? So anybody want to pick up on that introduction of both the health and social service needs?
Well, this is Greg. I'll jump in. I mean, I think first of all, when you begin to become responsible for downside risk, particularly when you think about a Medicaid patient population, social stability is critical here. You know, the folks that are showing up in our emergency departments and that are repeatedly ending up in our psych inpatient programs, those that are using lots of our detoxification services, and those that have physical health care problems that are really just exacerbated by a substance use disorder or another behavioral health issue and lack of appropriate safe housing. As soon as a provider network now becomes responsible for able to receive a bonus for upside activity and is going to receive a financial penalty for admissions beyond the norm, I think it now motivates a provider network to start having all kinds of different conversations with provider partners, home care providers to do transition from the ED to the home, housing providers to make sure that people that are unsafely housed at least begin the process of establishing supportive housing. So I think almost any design that starts to have a provider responsible for the whole person instead of producing a widget of care like a day or a visit is going to motivate, you know, thinking about the social determinants, especially as all the research is now showing us that that is as important, if not more important, than what we're actually doing with the healthcare dollar. We are actually strategically pulling our care management enterprises and our housing providers together to be working within these performing provider systems to start solving for some of these social determinant issues up front, so that providers have some packaged opportunities available as the value-based payment and the DSRIP performance measurement goals swing in. But some of this work will have to be owned by a newly motivated group of providers who are trying to, you know, address patient needs in a much different way.
Thanks, Greg. Anyone else have comment along those lines? Speakers?
This is Hope. I just really quickly, I mean, that since we're building population health, social determinants, however you call it, into the APC model, that is one of the key drivers we want to make sure that we pay for, is that team-based care and that connection. And part of our SIM grant is that we actually ask for money for what we're calling public health consultants. They could be called anything, but folks on the ground who can work to create that linkage between the clinical care provider and the community-based provider.
That's great. You know, the financial models that you've described from New York State really put providers and these regional coalitions in a new perspective of being motivated to first identify those social needs and then to muster resources appropriate to patient populations. We've been in a couple of discussions and conferences actually on this subject, and I believe that this is kind of a national movement in various ways that value-based payments are motivating those kinds of explorations by clinical systems to look outside the walls into the community and to see what the resources are. Just one real quick example that was brought up at a recent conference in Baltimore was a health system, a major hospital health system, that realized the need or the actual benefit in terms of their bottom line to Meals on Wheels for post-discharge patients, but then realized that the community didn't have enough Meals on Wheels resources, and then the challenges that health system faced in pulling out the savings, the VBID savings or the shared gains, and diverting some of what previously would have been clinical revenues out into the community to support that kind of expansion. At any rate, it's happening, but it certainly is happening on an accelerated basis because of these new financial incentives. I'll move to the next question, which is somewhat related, or I guess it's not the next question, but we'll come back to that. This is a question directed to Peter, but certainly I think both of you in New York may have some comment on this as well. It comes from Ron Bialik of the Public Health Foundation. Ron asks, are there opportunities for health departments to work with your insurance cooperative to provide case management? Peter?
Yeah, there would be. Hi, Ron. Nice to talk to you again. We actually have our own care coordinators who do case management. We do our own utilization management and disease management as well. So I think not so much with us because we're very dedicated to population health because of our backgrounds, but other insurance companies may not be doing that. So it certainly is a potential. It's a potential, obviously, funding source for health departments, which would be a great thing.
Greg or Hope, any comments on that, on working with health departments?
Well, was working with insurance. So,
well, I guess the question. I'm sorry, you were breaking up a little bit.
Sorry. Well, it's more in terms of care coordinators, really just working with the insurers to see if there's a model that can be developed that would pay for that as part of a value-based payment strategy.
There's another question, again from Cassandra Codes Johnson, and it's a general question. What are some existing models of value-based care that incorporate and pay for the provision of community health workers? Are any of you familiar with any of those?
Yeah, actually, we at Evergreen are. Sorry, Fran.
Go ahead.
Go ahead, Hope.
No, go ahead. It wasn't me.
Oh,
sorry.
We at Evergreen are actually talking with people at the Hopkins campus who have a career ladder of community health workers and trying to utilize them to do population-based health outreach efforts. So we actually are trying to do that, set such a thing up.
Great. Here's a question. I believe it's directed to New York State. It came up during your presentation from Kathy Rocker, who asked, do you have a viable health insurance exchange in order to gather this data? And I'm not exactly sure which data she was referring to, but perhaps you can answer more broadly about data coming off your exchange.
Well, the data that I went over is coming from Medicaid claims and encounters, and we do get enrollment information that comes in through our contractor, through the folks that are enrolled through the exchange. But we have an existing claims flow for our fee-for-service patients and an encounter flow for our managed care patients that is the driver behind most of the performance information that I was showing, including the diagnostic information, and we have cost. Our encounters are priced and costed out So we have a pretty rich database. But a lot of the work that we're doing now is to try to get more medical record data married to that claims and encounter data, and that's why we're trying to leverage our Medicaid data warehouse to become a little bit more of a data marriage platform. We bring in a robust set of care management data for the people with multiple chronic illness that are enrolled in our health home program, and so we get functional status data there. But we are working, to optimize performance by bringing in medical record data in that performance environment as well. But we do get feeds from the exchange, and there are issues with that cutover, like most states have experienced, and there's been interruptions in some data flows, which we are working on. But most of that data is just straight up administrative claims and encounter data.
Okay, thanks. Here's another question that's directed to New York. It's a lengthy question that I'm going to paraphrase by Mary Smith, who basically, she says she understands the payment transformation that is going on or that is contemplated between New York State's Medicaid and the regional coalitions and the providers. Her question is really upstream, and the question is really, to paraphrase it, is whether or not CMS, through your waiver, has kind of put the state of New York on a value-based payment scheme with regard to the federal contribution to your Medicaid costs.
Well, there's no reduction in federal share for the straight Medicaid payments associated with our value-based design. Where there is some pressure on us is there's a series of 4 tests that the state has on a statewide basis. And built into the test is that we establish our value-based roadmap and that there's some time frames there, and that we reach certain targets on the value-based swing, or a percentage of the $6.5 billion we get over 5 years for DSRIP is potentially compromised if we don't hit certain goals. And those goals are not all on value-based payments. Some of them are on outcome performance. Some of them are on cost and average cost reduction, et cetera. But there are targets and there are conditions we have to meet in terms of having that value-based roadmap and then making some progress along that roadmap that do potentially impinge us getting the full percentage of the DSRIP dollars.
Got it. Thank you. This next question comes from Judy Chaconis, and it's really to all the speakers. Asking both Peter from Evergreen and Greg and Hope in New York to give a few examples of how advanced primary care practices, or ACOs, in either your co-op or your plans are integrating public health services to improve patient outcomes. So if there's specific examples of how that might be working through your primary care practices, I think that's a question.
So this is Hope. I can go really quickly. There was a slide I went through that I went through quite quickly. Sorry about that. That is the APC and Population Health. And one of the key parts of the advanced primary care model is population health. That includes identifying patients for preventive or chronic care management, evaluating health disparities, and measuring and reporting on prevention agenda goals. Prevention agenda is our state health improvement plan in New York State. So we want to make that clear link between the goals that the counties and hospitals have identified as key in their region and the practices in that region. And identifying patients for preventive or chronic care management followed as necessary. A lot of the care coordination activities that might be a community health worker, but it might be somebody else. Those are other discussions we're having. But in terms of workforce, but really having as part of the clinical responsibilities that linkage with the population health and our public health prevention agenda in New York.
Great. Thank you, Hope. And yes, that slide, as well as all your others, will be up on on the ASTHO website. Okay. Here's a question that was submitted prior to the call. I think it's still relevant, and it's directed to Peter at Evergreen. The question reads, often there is quite a bit of turnover year to year among health plan enrollees. Do you think this turnover between plans and perhaps in and out of Medicaid reduces the incentive for plans to invest in prevention strategies that require several years to pay off in terms of lower spending?
Superb question. That clearly has been the case in the past when the average stay in a commercial insurer is 2.2 years or so. So there was absolutely no incentive for commercial insurers to provide preventive or primary care, and that's what we're sort of fighting back against here at Evergreen. And we think, I grew up in California, and I was a Kaiser kid, and they had me for 18 years, and 40 years ago they were talking about seat belts and helmets and all sorts of things because they knew they kept people for a long period of time. What we're trying to do at Evergreen, particularly with our high-performance network value-based insurance design, is to incentivize people both with lower costs and better care and lower copays and hopefully better outcomes to stay with us, to make it worth their while and our while to provide preventive and primary care and value-based insurance design. Obviously, we're a nonprofit health insurance cooperative. We have sort of different mission than other typical insurers, but that's clearly what we're trying to do. Very good question.
Great. Thank you. Is there anything that either Greg or Hope that you want to add to that in terms of the churn factor and the kind of cost benefit of applying prevention strategies that may not pay off in the short term?
This is Hope really quickly. Absolutely, that makes sense. But that's part of, I think, the drive for alignment, so that since we have multiple insurers across New York State, and obviously people do go in and out. So regardless of where you are, you'll want to look for a plan that offers that value-based insurance design benefit. So hopefully we'll get to a place where that will be a value benefit that people will be attracted to.
Fran, if I could just real quickly, we run
Sure.
a series of primary care patient-centered medical homes as well, affiliated with our co-op, and we specifically take co-op patients and Medicaid MCO patients. So we're dealing with the churn issue. So basically, if a patient loses a job and was covered under the co-op, they then could be covered under Medicaid and still have the same primary care center available to them. So we're trying to deal with the churn issue in that way as well.
That's a great point, and that's the alignment concept that Hope was talking about. So exactly along those lines, let's take the example of an enrollee an enrollee with HIV infection, and this reflects some of the other questions that have been previously submitted. An individual with HIV has short-term needs for long-term benefit. Would that patient be certainly would be welcomed into your advanced primary care practices both at Evergreen and at New York, but would the kinds of principles that you're putting forth for advanced practice primary care, do you see them bearing fruit in terms of the health outcomes of that HIV-infected individual as well as the lifelong costs? Would that be an example?
Who are you talking to?
Well, either of you, you for Peter, you for Evergreen.
As the ASTHO folks, I'm sure, are well aware, because of risk adjustment, the sweet spot for the Affordable Care Act, I think, is actually in risk adjusting for taking care of high-cost users or potentially high-cost users. And by risk adjusting, the insurer gets provided increased resources to cover those folks. And if you do a good job of managing them, for example, our case, diabetics, you actually get paid more for taking care of someone than it costs you. So you can actually make a profit as an insurance company while, very importantly, doing the right thing for the health of the individual, whether it's an HIV patient or a diabetic or et cetera. So that's what we're trying to do.
Great. We're back down to the last question before we do a wrap-up here. And this question is directed to Greg and Hope. And it's a structural question in that many of our listeners, and certainly ASTHO's members, are in state public health departments, but are not directly working on either the SIM grant or on any kind of specifically on financing or delivery reform. The question is, please describe New York State Department of Health structure and how the various departments within that super agency, Medicaid, Public Health, SIM, and others, integrate across the super agency.
I'll go really quick and then turn it over to Greg. Our prevention agenda that I mentioned, the State Health Improvement Plan, different than the State Health Innovation Plan, too many acronyms that sound the same. Anyway, they are both key measures, deliverables, and outcomes of both DSRIP and SHIP and SIM. So that is kind of the supporting infrastructure, I think, for both. And as I mentioned, in terms of our APC models, we're going to ask providers to pay close attention to those measures, which are clearly within the domain of the local health department. That's it. Sorry. Go.
Thank you, Hope. Greg, did you have anything else on that?
No, I would just say that the committee that's been working on our value-based design and our MRT group, those include folks from insurance, they include folks from our Office of Quality and Patient Safety that Hope works with, and we all report up to an executive here, and we're trying to stay integrated across what we're doing in Medicaid and what we're trying to do on the all-payer basis. There are many concerns in our constituency about going too fast and about not being careful, and particularly on the commercial side, there are many worries about what would happen if some of these more lucrative private contracts were compromised, and would that potentially have a negative impact on those same facilities' ability to serve Medicaid and uninsured patients, where they may use part of that revenue to cross-subsidize. So we have to be careful. We have to be thoughtful here. We have to keep all stakeholders engaged in the conversation so people don't shut down on this. But everybody's at the table, and we're in a listening and planning mode. But the nice thing with working with Medicaid is I think people can agree early on that Medicaid is a fantastic place to do some of this integration work and also to do some of this value-based purchasing work, because the margins are not what they are in some of the other payers. So it's a great way to begin the conversation with less threat.
Great. Well, thank you, Greg, and thanks to all three of our presenters. We're going to have to, at this time, end the Q&A session, unfortunately. If you do have follow-up questions, please use the contact information that you'll see on the screen in just a moment, and we'll be sure that our speakers get your questions. You'll also see on the slide just before the one that's on the screen right now, you'll see the very brief list of additional resources that might be of interest to you in terms of digging in a little deeper on value-based payment and design in general. So I want to take this opportunity. This is the last slide. We've had a lot of them here. I guess my count is up to about 60 slides, but they're really, really meaty ones. I want to thank you for joining us today. And again, to remind you that those slides will be posted, as you can see on the address there promptly at the conclusion of this webinar. Please take a few minutes to go ahead and fill out the evaluation that you can see the link for which is posted there on the slide, as it gives us really useful information for our future projects. I'd like to thank the Centers for Disease Control and Prevention for sponsoring this webinar, and again for our terrific speakers for their just really, really fascinating and informative presentations. We'll also have a recording of today's webinar, so if you want to have those 60 slides moderated, go ahead and download the recording. We do hope that you'll use this webinar as a resource and share the link with others once it becomes available. So again, I thank you all for your great questions, your terrific presentations, and hope you enjoy the rest of your day. Thank you.